Welcome everyone to the HSPN webinar in Evaluation and Logic Model Development. Please go online and click in the chat box and introduce yourself. I see many people already are. Nice. Wow, faster than I can even read them. Kathy Peters in Burlington, Jennifer Peckett in South Huron, Joe Dean from the Change Foundation. Welcome, Joe Dean. Craig Jones, Peterborough. Welcome, everybody. Please continue to introduce yourself using the chat box. Very much. We're going to go in about 1 minute. Everybody's still logging in, and we are getting ready to go. And Sleeman from multiple OHTs, and Adriana Diaz from London Intercommunity. Welcome, welcome. It's really wonderful to have everybody here today, and we are building a community around OHTs and around the evaluation of OHTs, and hopefully strengthening what everybody can do together. I would like very briefly to let you know about some of the people that are joining us today. I will host the meeting and be responsible for the general running and maybe have a few commentaries. My name is Walter Wochis, and I am the co-lead investigator for the Health System Performance Network and co-lead for the evaluation. So I am co-leading, and I'll start us off and keep us running smoothly. We have a great pleasure today. Dr. Kaylee McKellar, who's an assistant professor status at the University of Toronto and an evaluation consultant, and has done many local program evaluations, and will lead us through the how-to for a Ontario Health team to start thinking about using logic models in your evaluation. We have the great pleasure of two guests to speak to their Ontario Health team and one of their programs, logic models, and they've been developing for their programs, and they come from the North York Toronto Ontario Health team. And it's Jagger Smith, who's Program Director, Ambulatory Services at Baycrest, and Kristen Caballero, Senior Vice President, Community Services at Better Living Health, and she is also part of that. We also are very pleased that Anne-Marie Yaroskevich has been able to join us today. She's been a patient and family advisor in the Central East region for many years, and is currently a patient and family caregiver participant in the Durham Ontario Health team. And she will speak about her experience in working with the seniors care system and working with them to develop a logic model from a patient and family perspective and feedback on that. And that work has been loaded right into the older adults living with frailty focus in the Durham OHT. So how do we involve patients and caregivers in the development and implementation of the logic model? So thanks very much. So just a quick little overview that we have today. I will talk a little bit about the Central Ontario Health Team evaluation. Many of you would have participated in our webinar in December, and then we'll move right into how that relates to local logic models. I'll talk about example logic models. Well, I won't, but Jagger and Kristen will talk about local models from the North York Toronto. And some of you have actually started to send me your thinking around plans and logic models. So thanks for that. And I'll be happy to respond to you. And I think I'm going to work with the RISE team to see if we can work out a way for people to be able to create a community around sharing logic models and knowledge and learning. And there is lots of opportunity to take care of discussion along the way. And thanks to all who have been commenting in, appreciate it. And also people watch the chat. This is how we can communicate amongst each other throughout the time. Okay, we are building community. And just let everybody see me for a second here up in the corner, I think. We have 181 participants online right now, so welcome to everybody, and we're building community. Everyone's involved. I want to talk about the central evaluation first. People have heard me say before, and Ruth talk about how Ontario health teams have varied groups of providers, varied first-year target populations, varied resources, tools, and approaches. And particularly last week at the Ministry Forum and also at the RISE Day last week, we saw that quite a bit of variability, even amongst the groups that are focused in on similar populations and groups. We know that because of this, evaluation must be flexible and evaluation must be local, or should be local. And we're gonna, that's point of today, is actually how do we bridge this? From a high level standpoint, at a macro level, we have a formative evaluation of applicant OHTs. We previewed that before, and you're gonna hear more about it today and more about the results, actually. We're already coming in on that in the coming months. And then in the next fiscal year, starting in the spring, summer, we'll be moving to a developmental evaluation of candidate OHTs, which will be those that have been selected to go forward. And that will be an accumulating group of individuals. I will highlight that in this work, we will be flexible, not static. We will iterate. A year from now, the evaluation plans will look different than they look for us today. And today's emphasis is to start to support how evaluation can be made local. From the central perspective, the phase 1 formative evaluation is meant to understand the local context and assess strengths in the OHTs, such as leadership, common vision, and appropriateness of the specific teams. And so what does that mean from our view? Here is one view. We've taken it from a paper that we had published previously. It's not exactly what we're doing, but it's very close and gives you a view of what do we mean by this kind of context piece. We have in prior work on what does it take to implement integrated care programs, in a realist review of the literature with dozens of papers included, looking at how is it that those programs, when they evaluated the results, what were the essential ingredients to being successful in integrated care? And so that's this context piece. And we found that strong leadership and organizational culture, taking the time to build the infrastructure, being patient with getting things together, provider expertise in and training, flexibility in implementation. There also need to be provider incentives. That's not also always financial, but some forms of incentives, financial and otherwise, that engage providers in the models. And at its core, the key mechanism we've found is belief in and understanding of the integrated care model. And I think the clear translation to Ontario health teams here is in a belief in and understanding of the Ontario health team model. The area that you will be working in most closely after building that context is in this coordination of patient care. And that's where we're going to focus activities. I think, what is that? What does that mean? And out of that, we expect that we will see reduced health system utilization in some cases, improved health, hopefully in many cases, and improved patient and caregiver experience in all cases. That's the fundamental goals here. And so our work is going to be focused in these evaluation aspects of this context. That's our formative work. And in the outcomes, that's our developmental work. And that's what we will support. Locally, there's going to be far too many programs and heterogeneity, differences across programs for us to do a really great job for all the local programs. And so your work is to evaluate the activity locally on that coordination of care. And today is our first step in helping you towards that journey. And that's because there will be, at the outset, a minimum of 72 specific programs. And I think that's a little bit more than we can do a really, really rigorous job of. And so we'll stay in the ways that we can support. And so we're going to go now to Kaylee McKellar. And I hope that Kaylee will be able to come online, and otherwise I will be able to find you, I'm sure.
Hi, can you hear me?
Now we can hear you clear, Kaylee. Thank you very much.
Okay, great. So I'm going to give a basic overview of evaluations and get into some details about how to develop logic models. So on the next slide, we're going to start about what we're talking about when we say evaluation. So we heard the specific example from Walter about the OHT evaluations, but just more broadly, it is the systematic collection, systematic collection and use of information about a program. And so that can be about the program's context, activities, or results, and used for a number of purposes. And this could be judgment about the program. So does the program work? Is it effective? Or for understanding how it can be improved. So on the next slide, so now we'll look at how to do evaluation. So here we've outlined 10 steps for evaluation. So the first step is to engage users, providers, managers, leaders, and stakeholders in general in the evaluation. So we've listed this as step 1, but this is really something that should be happening throughout. So next, point 2, we have describing the program and context, and 3, developing a logic model. So these can go hand in hand, since a logic model is a way of describing a program. And as you know, this is the focus of this webinar, but we want to sort of place this in the sense of a broader process of evaluation. So next we have assessing the resources and the evaluability. And this is really to understand what the scale of an evaluation can be and what's feasible. And then next, we identify the important evaluation questions. So this could be, for example, is the program being implemented as intended? Or it could be, is the program having the expected results? So on the next slide, there's what we do in terms of planning is use the logic model to identify what the essential measures are for evaluation, and then develop an evaluation plan, and that's going to include how to capture the required data. So thinking about what data sources already exist, is there new data that you need to collect? And then 8, working into the implementation of the evaluation, actually collecting the data, and that's going to include capturing required data from program implementation, and is one of the reasons is one of the reasons why you want to be thinking about evaluation up front, because this can be sort of streamlined and integrated into the process. Then we want to analyze results and interpret the evaluation findings. And then finally, identify the audiences and develop reporting approaches and disseminate and use the results. Now, step 10, again, this is something that aligns with that step 1 of engaging the stakeholders, and actually is something that happens throughout. So I'll just acknowledge a bit of the work I know that some of the OHTs have done to date. So in submitting the application, there's been some identifying of indicators, and doing the planning really is involved evaluation thinking. So some of these maybe already partially be done. So on the next slide, we're going to focus on what is a logic model. So this is a systematic and visual way to present and share understanding about the relationships among the resources of the program, the activities that you plan, and the results that you hope to achieve. And it's really a way of describing the underlying rationale of a program. On the next slide is the common components of a logic model. So on the left, we have the resources or inputs needed for the program to create change. And we have that this enables us to do various activities to bring about the change. Now these two represent your planned work. And then on the right side, we move to your intended results. So this is broken down into outputs, which are direct products of the program. And then we have outcomes, which would be the intermediate results. And finally, impacts, so the long-term effects. So these are, I'll go over these again in some instructions, but these are the basic building blocks and common components that you see in most logic models. And I'm going to go through a couple examples. So we'll hear some great targeted examples from the North York OHT, but I do want to show a few others to highlight some key ideas. So on the next slide, this is a logic model of a transition care management tool. So it includes the key components that I just listed. So inputs and resources, activities, outputs, and then they have outcomes framed as results and goals. So here they highlight the movement from inputs to results, but with that arrow in the background, but they don't show the specific relationships. And this is a common approach. On the next slide, so this is an example logic model of a patient-centered medical home, and it's done by the Agency of Healthcare Research and Quality. So I'll highlight a few things here. One, they've included a description of the intervention in the model, so that second box. So these are often included in logic models, but maybe not necessarily within that chain or pathway, but it is a valuable piece to include. In this particular model, also I'll highlight that they did not separate outputs and outcomes, and we encourage you to do this, and I'll give you more detail on the difference in future slides. So in addition to those 5 core components, many logic models also include a statement about the contextual or external factors, and this is included there along the bottom, and still in the blue model. And then just highlight too, another key piece that is sometimes included is a box about the target population. So this is really key information to include, but we're actually recommending that that be woven throughout and when you're talking about your activities, outputs, and outcomes. So on the next slide, so this is the last logic model I'll show you, which is just from Immigration, Refugee, and Citizenship Canada. So again, this helps highlight that there's no one right approach or format to a logic model. So first, in terms of formatting, it flows from top to bottom rather than right to left. So activities are at the top, outcomes are at the bottom. And this is a fairly common format used in Canada, and particularly with the federal government. And they've also layered on some other aspects of the programs that are relevant in understanding their strategy. So they've broken out the various forms of service delivery. And additionally, I want to call out that they're a bit more explicit about which activities and outputs lead to which outcomes. So the relationships there are demonstrated by the arrows. So you can see that logic models can be flexible, use different formats to tailor to the program's evaluation needs. So next slide. Before we get into the how-tos, I just want to highlight some of the benefits of the logic models because it can really be a valuable tool throughout a program life cycle. So on the next slide, in terms of design and planning, so it's a tool that really you can develop your program strategy and enhance your ability to clearly explain and illustrate program concepts and approaches to key stakeholders. So a strong communication tool. It's also an opportunity to engage stakeholders, in particular around some of the fundamental assumptions of the program purposes, activities, and through that really create a shared understanding or be consensus building. So while the tool itself is useful, actually engaging in the process of developing it can be valuable in and of itself. So on the next slide, in terms of program implementation, it can really support management and maintaining accountability. It can help consider and prioritize the various program aspects, perhaps for tracking and reporting and making adjustments. And it also helps understand how the program changes over time. So logic models are living documents. They're not meant to be static. So the process of updating them helps you understand how the program's changed and also have some key conversations around this. So is it a matter of drift? Was it something more strategic? Are you okay with the changes? So again, similar to the planning stages, it's a really good communication tool for staff and stakeholders. And then finally on the next slide, in terms of evaluation, it is a useful tool in terms of guiding the evaluation questions, as well as facilitating measuring the degree to which the intervention has been delivered, as well as identifying program success. And really, it's a key starting point to understanding how the program works. So next slide. So before we get into some of the instructions for the logic model, just want to highlight that you should consider who should be involved in the logic model development. So program staff, participants, evaluators, patients, etc. And it's really recommended that you do this as a collaborative process with key stakeholders. So on the next slide, so this is a logic model template that we've provided for you. So there'll be some, we do have some additional resources that we'll post. This will be included among them. So you can see it has the 5 core components that we discussed. And we actually recommend populating this in a particular order that I'll go over in the next slide. So to start, we start with impacts. So what are the goals of the program? What are the issues that you're trying to address? So really, what are the fundamental changes that are occurring? And this is an area to start with to keep the overall goals in mind. Next, we move on to outcomes. So we want to get more specific about what you're trying to achieve, what changes do you expect from the program, and here we want to consider both the shorter term and longer term outcomes and be specific with the time frames. So the outcomes are the specific changes to, for example, program participants' behavior, knowledge, skills, status, level of functioning, health outcomes. Those would all fall under outcomes. Next, we would describe the activities. So what activities need to happen in order for you to achieve your desired outcomes? What are the processes needed to be in place? So activities are really the processes, actions that are taking. So you can think about it as what is the program doing? What are staff doing? And then I'll just highlight here again, I mentioned before about the target population. This is something that we want to work into activities and outcomes as well. So who is doing the activities and who's experiencing the outcome? So important to include that level of specificity. Then step 4, next we have described the resources. So what are the resources needed to enable the activities? And these could be human, financial, organizational, community, etc. And then step 5, we move on to output. So once the program's completed or underway, the activities will produce some evidence of service delivery, and these would be the outputs. So again, we want to specify some of the timelines for this and be specific where we can, and thinking about outputs as a direct product of the program. So before we move on to next steps here, I just want to call attention to the difference between outputs and outcomes, as it's a common question. So the outputs are the more immediate results, or they end up being more process oriented, and they would really help to answer questions like, is the program being implemented as intended? However, they're not necessarily the results. The outcomes could be considered the result or the effects of the program. And an outcome measure really helps us to see, is the program making a difference? So once we described these 5 areas, the next step is to review each area and consider if they align and if there's a logical pathway that moves from resources to activities, outputs, outcomes, and impacts. And we recommend the use of a pathway model on the next slide to help you explore those relationships. So this is what we're calling the pathway model or pathway logic model. So it's a type of logic model that is more explicit about the linkages between the different program components. And just to highlight here, this is different when we're talking than a patient pathway or a clinical pathway. So again, I'll highlight that this template will be available to you, and that you can tailor it to reflect the program's needs. So in building this out, you may want to start with one particular outcome and work out from there, but really there's no right or wrong approach to developing this type of model. There are a number of questions that you would want to ask yourself in developing them. So for example, do certain activities only require certain resources? Or for each of the specific activities that you have planned, what are the outputs or service delivery targets that you hope to happen? And then how will the outcomes you've identified connect to the impact pathway or to the impact? And then overall, really stepping back and looking at it. Is there a logical flow? Can you see how you can get from your planned work to your intended results? And then one other thing just to highlight is that there is room for creativity and modification in this template. So for example, if outcome 1 is viewed as most important, then you can do something like use a bold line or a color to represent that. Similarly with when you're displaying some of the relationships. So if there's a strong evidence-based relationship, you can highlight that in bold, or something that's less clear, a dotted line. So just like anything else, it really does take practice to use these as an effective tool. So I wouldn't hesitate to experiment with using this pathway model to design what works for your program. And also not to be concerned if it doesn't necessarily look like some of the case examples. So on the next slide, that was a pretty brief overview, but I do want to say that there are some resources available. So we've developed a logic model development exercise, which includes an overview of logic models, instructions, as well as checklists of what makes a quality logic model, a quality pathway model, and then as well as the templates that we've highlighted here for you to use. So those resources will be made available on the web to you. And then just touching on next steps. So once we've gotten our logic model, the next step is to focus on measures. So we think back to those 10 steps. First, we want to make sure that there's a clear understanding of evaluation questions. Then it's time to really get explicit about measurement. So aligning measurement with the logic model and evaluation questions. Then looking at the key data sources and what are the processes needed basically to monitor and take action. So I think now we'll hear some examples from North York OHT.
Wonderful, thanks so much. And Jagger, you're coming up there, and I see Kristen as well. So what we're going to do, I think, is go right into the looking at a real live example. I see some people are starting to type into the chat room. Please do communicate using the chat all the way along. I really love the bow tie comment. It does look a little like a bow tie, maybe more like a spaghetti knot. And I think we'll try and untangle so that things look quite proper and very pretty when they're all done. And we're going to see a couple examples right now, and you have to kind of step through them a little bit carefully. But welcome to Jagger and Kristen, and thank you so much for coming online to share your experiences in developing this, and not only your models, but also particularly your experience in doing so. I hope you can speak and be heard.
Great. Can you hear us?
We can, thank you. Good.
So we just thought we'd quickly introduce ourselves with our first slide. We are from the North York Toronto Health Partners, and we are representing one of the priority streams that we've selected for in our year 1 application. And we are, the way we formed, we are 20+ core partners and many, many more alliance partners, all coming together to sort of address the populations that we have decided to focus on.
Yeah, and so the logos for our core group are displayed on the next slide, and we are happy to get into the focus work of the seniors working group. Kristen and I built logic models for the seniors working group, and so I'll speak to that slide now, please, Walter.
And I just have to pop in quickly and just say, in addition to our core partners and our alliance partners, we have firmly embedded many, many patient, family, caregivers, and advisors in our work.
We have. It's a real privilege to be speaking to you today because we're building on past partnership successes across North York Toronto Health Partners. And I know there are some people on the line that have built up these programs that I'm going to sort of talk about, and so thanks for the chance to stand on your shoulders. Particularly, we've had some partnership successes in building one team over the past. By that I mean we worked with between Baycrest Hospital, North York General Hospital, and 2 community care access centers at the time to reformat our geriatric outreach team into an integrated community care team. And that team ensured that there was an interdisciplinary team that could support family doctors in the community to implement the complex care plans that a geriatrician often delivers. And so I'm really proud to have had the opportunity to lead that team at some point, but I was by no means part of the design of it. It's been a fantastic assistance to patients and families when you can take a family doctor and put them in the home with the home and community care coordinator. It's amazing what can get done there. And similarly, North York General has been one of the leading hospitals with integrated funding models, and they took on a bundled payment program for COPD and CHF patients. And again, that required multiple organizations to come together to deliver a bundle of care for some high needs patients. And it's a result of these kind of programs, ICCT and integrated funding model, that we have some sense of what it takes to put together a one team in terms of the inputs and activities that would be required, but also an ability to predict what our outcomes would be. The other thing that we've been able to do is to segment the population based on risk. And so in the bottom, or on the right-hand side of the slide is the Kaiser pyramid that we look at. And we've been able to take some of the data that the ministry's given us, particularly the health population grouper, and be able to see that, first of all, dementia is a big impact for seniors. Our Ontario Health team has spent $94 million on people with dementia in the years that the data was from. And we're also able to see some differences. So for example, people that have dementia without comorbidities had a total cost of care of around $7,000, whereas people with dementia with comorbidity had a total cost of care of $28,000. And the way that that helps us to think about is that different segments of the population have different needs. And we've started to imagine our future one teams as forming slightly differently to be able to meet those different needs. And in particular, we're planning to divide ourselves into specialized care coordination, which is a seamless coordinated home and community care team via these specialized clinical consultants that have the ability to adjust the care plan. And generalized care coordination, which is the same thing, one team, but more embedded with primary care and working on the logistics of service coordination. So slightly different needs for different populations of different risk, and we're imagining forming our teams with some distinctions there. And then, so that is how we've been thinking about seniors, as well as how we've been thinking about care coordination in North York Toronto Health Partners. And so we've built two logic models, one for specialized clinical coordination, which I'll speak to now, and the second for generalized care coordination, which Kristen will speak to in a moment. The last success that I want to talk about us building on is really the patient and family partner and the wisdom of the team. So in developing this logic model, I've got some fantastic feedback from our patient and family partner, and I want to thank you directly, Wendy Wu, for helping to understand how the concept of a logic model translates into the practical kinds of impacts that you expect to see from an integrated health system as a patient and family partner. And many of us in our organizations, not me, but on our team, have experience forming logic models within our organization for program design. But this is all new to be doing a logic model across multiple organizations. And so if I could show my draft logic model at this time, I'll walk you through it and offer some other insights.
Yeah, and I'm going to go right to that, and I'll just ask for both our speakers. A few people in the audience have had, not everybody, a few people with difficulty speaking, so just be sure that you're projecting very clearly.
Okay, thank you. I will speak up. It's a big empty room. I'm projecting to the back of an empty room. Okay, so we organized the relational logic model as Kaylee described. I found that there were two big chunks of work inside the logic model. One was the work of setting up the program, and that's what we highlighted in blue. And then the second was the work of actually delivering the program, which I highlighted in green. And then I gave some yellow comments so that I can call out some particular arrows for discussion. So I appreciated the opportunity to describe the work that a lot of us are doing right now in terms of putting inputs of partnership and trust and trying to create connectivity and consensus through activities like finding shared definitions of care coordination, leveraging our previous redesigns, and identifying the existing programs and services that can come together. Because we do not yet have the output that we need of a program model itself or standard work for how to deliver that. And it's one of the things that I've been learning in the development of Ontario Health Teams is that this is real work, and it does require inputs of time and energy, but also activity to be able to create an outcome of integration, an outcome where we can expect to improve patient and caregiver patient-reported experience measures, but also improve team functioning and improve provider experience. So that's the blue section. And then I took it with a yellow arrow right back to the beginning in terms of offering a feedback loop, because once we're able to produce a shared program model, then we can write a business case around it and we can have a business case approved. And it's only once we've got the business case approved that we can expect to have the liberation of human resources, financial resources, and digital assets to be able to do the activity of the program. And so now we're into the green, and we have activities like training the teams, identifying our year one patients and consenting them to the program, and then outputs of the teams following new standard works, patients being screened into the program. And eventually we expect to enroll about 680 people with dementia, COPD, and CHF into the program. And the expectations of the program is that it delivers on some longer term outcomes over 24 to 36 months. And we're able to, again, from our previous work, know that we want to improve things like self-care, the self-care heart failure index, the 6-minute walk test for COPD, and down at the bottom, also decreasing readmissions, reducing emergency department visits, and avoiding that value break towards $28,000 of dementia patients. And ultimately, the impact being better health outcomes for seniors and lower total cost of care for seniors. So just to speak to the yellow bits, the yellow box around training teams on program model and new standard work, that's to identify that we need to develop that program model and standard work. The backwards arrow, I think that having a feedback loop gives us permission to acknowledge the hard work that goes into to developing integration. And then there's lots of room for debate inside of a project model. And so it's been suggested to me that we need a big right arrow to a big yellow arrow to the right, where training of the teams follows into patients being enrolled. And I'm not so convinced of the sequence there. That's a wonderful chance for our working group to debate how the program will roll out. And then finally, I highlighted inputs at the top left and 24 to 36 months at the top right, because that's really the business case. Are the inputs going to drive the outputs that you're expecting? And the chance to put this logic on a page and show that balance and find with the team what the fulcrum is in terms of, does the investment get the output? Is the output warranting of the investment? It's a good way to be able to have that discussion. Mm-hmm. So that was STC. Can you speak to
I can. I'm just gonna step in and try and project my voice to the back of the room. If we move to the next slide quickly, you'll see that there's some significant differences between the model that Jagger worked on and the model that I worked on. And that really represents the different places that each of us started. And I'll just, as a sort of warning, say that we worked on these logic models as just a very first basic step towards getting to the end result, which should be defining what the activities and the final outcomes of our models are. So I know that Jagger had the opportunity to be involved with a specialized care coordination group at a much different point in time than myself. So a lot of the work that I did was taking some of the work that I had not personally been involved in around preparing the OHT application and envisioning what generalized care coordination would look like and inserting it into this logic model. So this doesn't represent sort of what the working group has identified moving forward, rather what the initial vision was. And I think that Jagger and I had many opportunities to come together and sort of discuss where our models crossed over. And one of the ways that we tried to represent the state of our logic model was through sort of the blue outlines versus the green. And so the blue outlines being more the activities of the project versus the green outlines being the actual ongoing activities of the model. And so I guess for that reason, we're hoping that eventually over time and through work with the group and work with our patient and family advisors, that our models will evolve to be all green, and that we'll be using this tool. And that was really a big learning for me, using the tool to build consensus and using the tool to answer unanswered questions. And so some of the things in my model that I try to represent were a lot of the activities that we have to do to get to the model, and that's really identified in the activities column. I really don't have, through the application, any finalized sort of concrete processes at this point in time, and that will be the work of the group going forward. In the outputs model, there are some, deliverables that have already been identified through the application process. And we had some really good conversations, and I think Jagger identified this as well in his model, and I sort of used a red box to outline. And just as an example, because I think there are many more questions than what I've identified here, and I've used sort of red to say we haven't identified the number of rising and risk seniors we want to engage. We haven't identified what the outcomes of some of those human resources driven and digital driven inputs would be. So the model for me has been a great tool to sort of lay or map out all of the vision that we've had to date and to identify where as a group we need to focus in further to take our logic model to the next step. The only other thing that I would point out, well, Jagger and I have different populations or specific populations that our logic models are seeking to address the needs of, that there's a lot of overlap. And so this has been a great opportunity because we're working with a number of different populations in our year one initiatives. I think this model and the common use of the model will provide a great opportunity to compare and contrast in terms of, are we using similar measures? Obviously, we all across the OHTs have similar objectives or similar goals in terms of the impact that we want to have. So where can we align, and how will that sort of facilitate better quality improvement, both within our own OHT and beyond? Those are my main learnings. I think we did a little bit of a summary sheet that we thought we'd share back and forth in terms of what some of our insights have been.
Yeah, so it's been a great experience working through this over the last week or so with Kristen and with the working group that we're within. And I've found that crafting a logic model is actually a process of engagement. It seems like you're writing what you know into some boxes on a page, but it's the discussion that's able to come out through that writing. And it is harder to do this with multiple organizations, multiple stakeholders. And it's nice to have a tool that you can write in and email back and forth to be able to facilitate the discussion. So thanks to my team for all the great feedback that we've got so far. We've got a lot more work to do.
Right. Yeah. And particularly for us with the parties or the groups or the organizations involved in sort of moving these initiatives forward, I think that the logic model will play a particular role in sort of building some of that new community or enhanced community that we need to sort of move our initiatives forward. The second point that I wanted to raise, and I think I already alluded to it, was that we really see, and we came to the conclusion as we sort of work through this, that this is absolutely a living document. Not only would we use it to find some common understanding, but to reflect our common decisions and our common outcomes, and to be able to track the evolution of the models that we develop with the group.
And then the last thing we were realizing is that a logic model is a helpful way to manage the adjacencies that come in. So we knew our projects were adjacent, but the opportunity to really just have one all-green model together between generalized care coordination and specialized care coordination. And also other adjacencies that come along. There was a research program that came to the seniors working group just this past week, and I was able to say, oh, this does fit in with the logic model. We're collecting similar measures. And so, yes, let's do that research program. And it's been helpful to be able to quickly make that distinction that this is something we can do and fit into the scope or not.
Yeah.
And that's, thank you very much, Walter and Kaylee and Ruth, for the chance to work through these logic models with you. We've learned a lot, and that's a summary of the insights that we've been able to have so far.
Thank you.
That's great. Thanks very much, Jagger and Kristen. And I know that we already have some questions coming in for others in the chat. Please add your questions to the chat, and Kristen and Jagger, stay nearby to your mic. You're by mute for now, but we'll have you come back on in a few minutes. I would, right now, we have the great pleasure of Anne-Marie Yaroskevich to participate today. And as I mentioned at the beginning, at the outset, that Anne-Marie has been a patient and family advisor in the Southeast region for many years, and originally was part of developing a logic model and feedback for that through the system senior design and through the Seniors Care Network in particular, and looking at the logic model that they have built. We're not going to project their logic model today for you, but instead have Anne-Marie speak to her involvement. And I think this is exemplary as we've talked about evaluating and moving into Ontario health teams, the importance of family and patient engagement in this work, and that stems right from the outset of the planning and process, and through this stage of talking about what your logic models do, because it really is
Hello, Walter. Can you hear me?
We can hear you.
You can hear me?
Thank you, Anne.
Okay, super. Okay, thank you for this opportunity to share information on the program logic model for seniors care system and my involvement and the involvement of other patient and caregivers in the development of it. The program logic model for seniors care system was developed by the Seniors Care Network, which is a network of health professionals with a focus on specialized geriatric services in the Central East region of Ontario. I was involved in patient engagement activities related to the development of this model, as Walter had mentioned. In September 2019, as the development of Ontario health teams was beginning, the Seniors Care Network shared this tool with OHTs developing in the Central East region. This included the Durham OHT, which I also happen to be a member of. This model was among the reference documents used by Durham's OHT's working group that was focused on preparing the submission for the older adults living with frailty priority population portion of the OHT's October 2019 full submission. And I was a member of this working group. My 15 years as a voice for patients and caregivers at the system planning tables in the healthcare system has taught me the importance, truly taught me the importance and value of having patient and family advisors at healthcare planning and design tables. My journey has also taught me the importance and value of also hearing the larger voice of patients and caregivers in the community at large. Now, my experience in the development of this program logic model reinforced this for me. And I was also very pleased to hear the importance of citizen engagement noted by the previous speakers. Now, my involvement in the development of the model was at a planning level and co-design level. I'll just share what my involvement had been and also share that of others. Going back, actually, it goes back away to 2013, myself and a fellow patient and family advisor developed the seniors system design framing questions, which helped guide the work of the team developing the logic model. And that was a great opportunity. The leads in working on the development came to myself and my colleague and said, we'd like you as patient and family advisors set out a group of questions that we need to keep in mind when we're doing this work. Giving an example, a few of them were, have we actively engaged frail seniors and their family caregivers in the system design, including hearing their stories and their healthcare experiences? Another one was, will this design truly meet the care and support needs of seniors? How will we know? So these were among the questions. There was a total of 6 questions. So that was very reinforcing for myself and my colleague, who happens to be one of my fellow peers on the Durham OHT. So it was really positive reinforcement for us that that team truly was looking at, the team developing the model truly was looking at being sincere in patient engagement. Another area I was involved in, so with myself and another patient and family advisor, we're involved in co-designing the Seniors Care Network Citizens Engagement Framework with Senior Care Network staff. And this document guided citizen engagement activities related to the logic model. And so that framework includes a strategic goal, has 10 guiding principles related to engagement, citizen engagement. It has three strategic directions, talks about the utilization of different engagement methods and enablers. So I've been very pleased to see that has guided the work, engagement activities related to the logic model. And this actually is as recently as this past summer 2019, I was one of 6 patient and family advisors asked to review and provide feedback and input on the draft logic model that had been prepared as a result of different inputs received from the community. And also, of course, there is input from providers working in the field of in providing support to older adults living with frailty. Now, 4 of the patient and family advisor members, they had tied to Senior Care Network, but they were also participating in Ontario Health Teams, which is great to see in our area, in the Central East region. And 2 of them, myself and one of my colleagues on our OHT, were involved in this. Now, throughout my involvement in each of these activities, I truly have felt that my opinion and feedback were respected and truly valued, and were helping in the development of the logic model. And the proof in the pudding was seeing my input and that of my peers incorporated into the model. So very important as a reinforcement. Now, the citizen engagement in the development of the model has gone well beyond my involvement. And I'll give you an example of some of the other areas of citizen engagement. There were consultations conducted by the Seniors Care Network team members during the development of the action plan for dementia. Staff research included interviews with older adults living with frailty and their caregivers, staff members' own lived experience, because many of us on this call, if not all, can put on hats of having been patients, having loved ones, caregivers, and also mentorship of staff by older adults, and feedback collected through staff participation in Canadian Frailty Network Engagement Committee. So as you can see, there was a wealth of patient and family engagement and input into the development of this framework, this logic model, program logic model. Now, you'll see, as I noted here, the value of this program logic model and Ontario Health Team's work. I'll tell you, I got involved as a result of a journey with my father. And that journey, after my journey with my dad, my hope was to help improve the system of care and support for older for patients and caregivers, with a particular focus on older adults. And I truly, sincerely believe that this model can be used by OHTs to help guide the work in supporting, and it's very much in supporting for good, strong, robust, best-in-class seniors care system. And a number of the elements that were discussed by the previous presenters actually are incorporated, are among the elements included in this logic model. So the value I see for the model for the OHTs across Ontario that have a focus on older adults is to take the model that has rigorous work been done into putting it together, and seeing of the 7 elements, which ones would apply in the work you're doing in year 1 and beyond. And from there, what I would see happening is those being incorporated into the logic model design that we saw earlier in the presentation, today's presentation. Now, the voices still needing to be heard, those are the voices of patients and family members and caregivers within your own OHT. And because it's great to have all of this information and input at a provincial level for the model that's been developed, but 100% that the needs and the high priority areas will vary across Ontario. So there's definitely the need at a co-design to have patient family advisors at your table with you when you're putting together your models, but also to have the avenues and the network to reach out. We use the term in our OHT, communities of practice among patients and family advisors to hear the community voice and helping ensuring that your logic model truly is meeting their needs. So I'll leave it at that, and thank you for this opportunity to share my thoughts and the information on the model. Thank you.
Oh, that's so great. Thank you very much, Anne-Marie. And it's been a learning for me to understand how you've been involved. And I think both your commitment over time, but also particularly continuing through different iterations, regionally, locally, and now in Ontario Health Teams. I think that will be very much advantaged for your participation. I would like to just encourage everybody now. We're going to really open this up. We're going to have a poll, and then we're going to open it up for discussion, and we'd really like to have people engage. One of the things is you may have some questions today, so I know Kaylee, Christian, and Jagger are still available, as is Anne-Marie, for another 15 minutes or so. And please use the chat box to answer any ask questions. So very much appreciate people coming. I want to let people know about a couple other things which may even open it up and answer some other questions. Go ahead. So one of the things is just reminding people of some of the resources that are available. So first off, the Ontario Health Teams Digital Playbook being one of the examples that's available through the Connected Care Government of Ontario website. RISE is also creating an interactive website, and we'll look to partner with them. We are partnering with them, and I think this might be, and people seem favorable, or at least some people, to maybe creating some space there for sharing Ontario Health Teams logic models. And so we are going to continue to work with them. Here are some resources for us. And actually, I just noticed on the previous slide, we had HSPRN. And as of this morning, that site will point you to where it should, which is hspn.ca. And if you go to the hspn.ca website, you should be able to track pretty easily into our evaluation and Ontario Health Teams section, from which you'll see our links to our practice guides around implementation for organizations to implement through change management, thinking about involving patients and caregivers, what the work needs to be with providers, managers, and finally collaborative governance, which is all packaged together in a one resource document. We also have available from today, people were asking about this, today's slides are currently already available on this website. If you go to the logic model section, along with this workbook that we have prepared for people that includes some of the content and steps people through developing their own logic models. Also, you'll find attached to their PowerPoint and Word document templates that you can go in, just like the ones that Kaylee had up online today, because they were developed by Kaylee, to go in and start to use them to populate them yourselves. You can develop these all entirely on your own, but just a few tools that might help you to get started in this work. So in Word and PowerPoint, as well as the PDF of today's slides, and this little exercise book that leads you through the development of practice guides. So that said, thank you very much. We'll look to continue this conversation, and everybody should be paying very much attention to the fact that this is our inaugural of our fourth Tuesday of the month webinar series. So fourth Tuesday of the month, every month for the foreseeable future, we will be tuning in online. Today we had 196, I think we might have peaked over 200 people online at the peak time. So that is strong engagement, and we have room for more. So tell your friends, and we'll continue to get the word out. Upcoming topics will be around generation of integration, lessons learned from past experience in Ontario integrated care projects. The Ontario Health Team formative evaluation results, they're starting to come in. We'll be sharing them back out through this format. Focus on measures for local evaluation, the next step in logic models, as well as developmental evaluation coming forward, and many more topics to come. Put us in your calendar, 12 to 1:30, fourth Tuesday of the month. Really want to thank especially our speakers today. Discussants did a fantastic job of leading us through and really letting us know, so giving us some guidance posts. So everyone is involved. That's our mantra. HSPN.ca evaluation Ontario Health Tanks. Follow us at info_HSPRN. That will switch over to our new Twitter tag in a few weeks. But for now, you can follow us there. And if you have any questions about the evaluation in our team, please feel free to email us. Thank you all very, very much for joining. And good week to everybody, and good luck with your Ontario Health teams.